Now quickly brushing through the questions asked in the topic of ascites. So this is the basic physiology. In hydrostatic pressure will push the fluid out of the capillary, and on the osmotic pressure will keep the blood inside the capillaries. So if there is increase in hydrostatic pressure, fluid will move out. If there is decrease in colloidal pressure, fluid will move out. So there will be edema. This is the basic pathophysiology. So brushing through certain important MCQ. If the onset of ascites is sudden, there is acute Budd-Chiari syndrome, acute right heart failure, sudden decompensation of previously decompensated cirrhosis, or pancreatic ascites. If the onset of ascites is insidious in onset, then it is decompensated cirrhosis, chronic Budd-Chiari syndrome, TB ascites, nephrotic syndrome, hypothyroidism, or chronic pericarditis. Now coming to the grading of the ascites based on severity. Grade is 1 if severity is mild. If the puddle sign is positive or USG abdomen shows ascites. It's grade 2 if the ascites is moderate, if shiftal dullness is present but no fluid thrill. And it is grade 3 if there is severe ascites when fluid thrill is present and respiratory distress is there in the patient. So this question is asked, what is the minimum amount of fluid is required to detect by CT scan? It's 100 ml. By USG it is 100 ml. Fluid thrill is 1000 to 1500 ml. Shifting dullness is 500 ml. Puddle sign will detect a fluid of 120 ml, and for diagnostic tap of minimum fluid requirement is 10 to 20 ml. So for diagnostic paracentesis, the fluid is around 10 to 20 ml. The bladder should be emptied prior to the procedure. Most common site is left lower quadrant. Other sites are in midline between the pubic symphysis and the umbilicus, right iliac fossa, lateral to the inferior epigastric artery, or a few centimeters above the inguinal ligament. And for diagnostic paracentesis, the technique used is the Z technique. Indications for diagnostic tapping are new onset ascites to determine the etiology, to differentiate between transudate and exudate, to detect malignant cells, and suspected spontaneous or secondary bacterial peritonitis, that is SBP. Coming to the contraindications of the procedure is severe coagulopathy, abdominal wall hematoma, any kind of local infection, or any repeated surgeries in the patient. The complications of the procedure are infection and peritonitis. There can be bladder or bowel perforation, hypovolemia of the or shock. If greater than 1 liter of fluid is removed very rapidly, especially if the patient does not have edema, and there can be blockage of the needle. So, difference between transudate and exudate. So, exudate protein should be more than 3 gram. Transudate protein is less than 3 gram. Specific gravity is greater than 1.015. Transudate it is less than 1015. LDH is high. LDH is low. In fibronectin, 75 milligram percent malignant ascites, it is low, right? Cholesterol is low in case of transudate, whereas it is high in case of exudative ascites. Hyaluronic acid is more in case of exudative ascites as it is low in case of transudate ascites. ADA is high in tuberculous ascites and low or normal in case of transudative ascites. So this is a very important slide. So based on SAG ratio, if the SAG ratio is greater than 1.1 and it is less than equal to 1.1. If it is less than 1.1, there is biliary leak, nephrotic syndrome, pancreatitis, peritoneal cancer, carcinomatosis, and tuberculosis. If it is greater than 1.1, then you see the ascitic protein, which is less than 3, or it is more than equal to 3. So if it is more than equal to 3, it is congestive heart failure, uh, then early Budd-Chiari syndrome, IVC obstruction, and sinusoidal obstruction syndrome. If it is less than 3 gram percent, it is cirrhosis, late Budd-Chiari syndrome, and massive liver metastasis. So, based on high sag gradient and low sag gradient, high sag gradient, the causes are cirrhosis, veno-occlusive disease, Budd-Chiari syndrome, fulminant hepatic failure, cardiac ascites, mixed ascites, and massive liver mets. Based on low sag gradient, it is tuberculous ascites, nephrotic syndrome, pancreatic ascites, chylous ascites, biliary ascites, serositis in collagen disease, peritoneal carcinomatosis, postoperative lymphatic leak, or bowel obstruction. Now coming to the complications of ascites, which is spontaneous bacterial peritonitis, hydrothorax, GE reflux, respiratory distress and atelectasis due to elevation of the diaphragm, inguinal, umbilical and femoral hernia, scrotal edema, collection of fluid in the pleural sac, there is pleural effusion, mesenteric venous thrombosis and renal failure. If the color is straw colored or bile stain in cirrhosis, clear, tubular, turbid or hemorrhagic or chylous in case of tuberculosis, turbid or purulent in case of pyogenic peritonitis, CCF it is straw colored, straw or chylous colored in case of nephrotic syndrome, turbid, hemorrhagic and chylous again in case of pancreatitis, in case of neoplasm it is straw, hemorrhagic, chylous or mucinous. Protein is less than 2.5 in cirrhotic. TB it is more than 2.5. Pyogenic it is again less than 2.5. CCF variable, and in case of nephrotic syndrome less than 2.5. Pancreatic ascites more than 2.5, and neoplasm it is very high. Now, SAG ratio is described previously. I'll come to quickly to the WBC cells. It's important usually. Less than 250 in case of cirrhosis, or usually tuberculosis, it is more than 1000, more than 70% will be lymphocytes. So you have to do a peritoneal biopsy. Pyogenic will be predominantly neutrophils. The gram stain will be positive. CCF will be usually mesothelial cells, mononuclear cells will be found. Nephrotic syndrome, it is usually less than 250. Pancreatic ascites, it is variable. And neoplasms will be more than 1000. It will be positive for the malignant cells.